Hello everyone. So we can have this discussion about the perforating dermatoses. And what you have to note here, in this case, when you are labeling these skin conditions, we can either say it is a dermatitis or a dermatosis. So that is different. So in this case, we usually don't have an inflammation when we say dermatosis. You understand? There's no inflammatory process. In this case, when we talk about dermatosis. So in this case, we are going to look at disease conditions that can actually cause perforation or pass through the layers of the skin, either to be expressed up or pass from up going down. So those are the conditions that you're going to talk about today. So as you can see in these pictures, we see in the first picture here that I have on my screen, you'll see these papular nodular lesions on the leg that have a white central core or plaque that is very similar to when you see other things like the prurigo nodularis. It may confuse you thinking that maybe it is prurigo nodularis, but you have to take note of this typical morphology where you have a lesion having a central whitish core. So this is the same arrangement that you have here. And when you do dermoscopy, you'll see the central core here, and then with surrounding telangiectasia or even blood vessels and erythema. Then when you do a histology, this is the picture I shall be looking at, and we are going to explain which particular disease processes or conditions can give you this type of picture of skin lesions. I am Dr. Abraham from A&D Dermatology Specialist. So starting with perforating disorder, these are skin disorders where we have material being expelled from the dermis, the skin surface, through the epidermis. So this is usually done through a process that we have termed, or that they have termed as epidermal elimination, TEE. And it is very key for you to understand that term because the perforating disorders can either be pushing materials out, or sometimes the material comes from out and it perforates through the epidermis, through the dermis, to reach even the subcutaneous or the subcute layer. So we have associated conditions which includes the acquired perforating dermatoses, oftentimes linked to diabetes and also chronic renal failure and other things like elastosis, perforans, serpiginosa, and this has also been linked to other connective tissue disorders or even Down syndrome. So when you look at the history, these perforating disorders were first described by Kyle in the 1916, where he described a diabetic woman who had this hyperkeratotic nodules. And by that time, he called it the hyperkeratosis follicularis et parafollicularis incremens penetrans. So this is just describing actually the actual process or the actual presentation where we looked at this patient having hyperkeratotic follicular papules that were penetrating actually through the epidermis, and that's why we put the word penetrans, and it was in a diabetic woman. Then later on, Lutis comes in the 1953, and he introduces the term elastosis, perforans, vaginosa, EPS, and by that time, he called it keratosis follicularis vaginosa. And then later on in the 1955, then Nestia documents the histological feature where he called it herastoma intrapapillary perforans verruciform. So in this case, for him, he thought that they looked like actually like verruca, like the warts, but then in this case, they were perforating actually through the epidermis to reach the dermis. Then Mary Hagan with his friend and Living Good, they reported the first case of reactive perforating collagenosis in a child. That was about in the 1967. Then later on, the next year, American came in with Koski, and then they expanded the concept of perforating disorders to actually even include the perforating folliculitis. So when you look at how common are these conditions, we have them occurring globally with no racial preferences, and we can have adult onset, especially if you have reactive perforating collagenosis, and then EPS can also be familial, and we have also isolated EPS or elastosis perfringens spaginosa, which may also follow. an autosomal dominant pattern of inheritance. So when you look at the gender differences, you'll find that these conditions, especially the EPS, is more common in men compared to females. That is a ratio of about 4:1. And then whereas other like reactive perforating collagenosis and the acquired forms of perforating dermatoses, for them they don't have actually gender bias. They occur equally in both males and females. So when you look at the prevalence, when you go to the very sick patients, those ones on hemodialysis, you'll find that they have a greater burden of these perforating disorders, contributing to up to even 11% of them end up having this acquired perforating dermatosis. So when you look at these terminologies, the perforating disorders, transectdermal elimination, various authors have tried to describe these particular conditions in different ways, but you'll find that all these processes they're trying to explain, they're actually the same processes. And when you look at the histology will have this key feature where you have the perforation of the epithelium, usually with either with collagen or even elastin. So when you are classifying these disorders, you find that you have other things like perforating folliculitis, and this is still in use in literature. However, some recommendation, the current literature suggests that this term actually should be abandoned because actually they think that it doesn't make a lot of sense. And then you have things like acquired reactive perforating collagenosis, and now this is now referred to simply as the acquired perforating dermatosis, such that because it involves both the collagen and then the elastin, the material that is being eliminated. So then we have transepidermal elimination, which has also been seen in other secondary conditions, where you're either eliminating inflammatory cells, red cells, or even macrophages, or even intracellular substances that can also be eliminated actually through what? Through the skin. So all those conditions are now classified better. So the primary acquired disorders, this one usually have the acquired perforating dermatosis, oftentimes associated with diabetic people and renal disease patients, and then the elastosis perfringens perforans spaginosa, the one that's associated with connective tissue diseases and Down syndrome. So this classification now puts the acquired perforating dermatosis in one category, and then we have now the one because in that case we put it in one category, then you'll have the elastosis perfringens perforans spaginosa as another entity. Then you can now have the other bigger group where you have now the acquired forms that can be because of any other dermatosis. So the term perforating folliculitis has been dropped, and people are no longer using it even in literature. So when you look at the pathogenesis of this particular condition, you'll find that the exact or the precise mechanism is not yet known of how this concept comes about. However, we have this all thinking or line of thought that you have transectdermal elimination of undesired proteins or components from the skin, from different layers of the skin through the epidermis to contribute to this process. So in this case, we've seen that you have the epithelium, which usually becomes hyperplastic. Then it will surround that abnormal connective tissue, the same thing that you usually see in foreign body reactions. For example, if you have like a splinter or a thorn in your body, your skin will try to engulf it from outwards into inwards to try and take it out actually. So that is what we are thinking, that in this case, the same process happens when your body tries to eliminate actually the abnormal connective tissue that may be in the deeper layers. So there's also a thinking that is a role played by pruritus as well as flushing, and this is seen in the acquired types of perforating dermatosis. And there's a thinking that the itching or the chronic pruritus can lead to hyperplasia of the epithelial layers, and then at the end of it all, you end up forming those elongations into the dermis and try to eliminate the damaged connective tissues below the skin. Then there's also this theory where we have the theory called hyperkeratotic plug hypothesis. This one suggests that a growing plug in the epidermis can actually push outwards to cause a perforation. So in this case, there's a thinking that whatever is abnormal is inside, it is continuously growing, then it pushes through the upper layers to actually get eliminated through the skin. So there's a component of either it is these acquired or these perforating dermatoses are either genetic or acquired, and the primary diseases may involve genetic or even acquired abnormalities of collagen or even elastic fibers. However, other things like the EPS and some other acquired cases have been shown to have elevated elastin receptors found in the affected area. So these ones have just been found in lesional skin, but their implication has not yet been well understood. So when you go to other molecular key players in this um, dermatoses, you find that age is what we call the age-modified proteins, and there's a thinking that these age-modified proteins, that like maybe as someone grows, the proteins they're producing become maybe damaged, defective because of maybe age, and then as you are scratching, there's an exposure of keratinocytes to these glycations and end products, and this leads to the terminal differentiation and then movement of the glycated collagen. So as you grow, maybe collagen or other tissues become old, other proteins, and because of this, as maybe you're trying to scratch, even the keratinocytes that are within the epidermis get exposed to these damaged proteins and then trigger a response that results into their elimination. Then there's a thinking that fibronectin, which is seen to be elevated in the diabetics and uremia patients, plays a role in promoting cell signaling and proliferation. And this gives a net result of you forming that hyperkeratosis, and then that engulfs the abnormal tissues that are below the abnormal connective tissues. Then we have things like collagen and then growth factors. For example, type for collagen, and then there's also an increased transforming growth factor beta 3, and then matrix metalloproteases, especially one, and then the TIMP1. There's also a suggestion that maybe they're also involved in the wound healing at the same time, also involved in this process of elimination of substances from under the skin through the epidermis to the exterior to the environment. So other theories, there's also a potential role being thought of where there's thinking that maybe abnormal vitamin A or B metabolism, neutrophil enzyme release, and diabetic microangiopathy contributes to these processes of perforating dermatoses. So when you look at the classification, these are the major perforating diseases that we have. The first one is the familial reactive perforating collagenosis, which is a little bit very rare, and onset is oftentimes in childhood. It loves the arms, the hands, and then also sites of trauma. And the substance that is being eliminated is the collagen, and it has no other associations. When the second one is the elastosis perforans serpiginosa, also called EPS. So this is a little bit rare, but more common in males than females. And it can have an onset either in the childhood or adulthood with variable onset, especially if it is induced with this drug penicillamine. So if it is induced by penicillamine, it can occur at any age. So it also lasts the neck, the face, the arms, and other flexural areas. And in this case, eliminating the elastic tissue as the component. Then it can be associated with other genetic disease, and then also use of penicillamine. We see it being associated with Down syndrome. Then we have the perforating folliculitis, which is a little bit more common. Onset is in early childhood, commonly seen on the trunk and extremities, and in this case, you're eliminating necrotic material. So may simply be ordinary folliculitis with a follicular rupture, and actually there's no, it's not a specific entity. That's why I was telling you that in most literature they have actually dropped this folliculitis. Then we have the acquired perforating dermatosis, which includes the acquired RPC, then Chiari disease, as well as the acquired EPS. So this is a little bit more common. 10% of dialysis patients will have this. And then we onset usually in adulthood, commonly seen on the legs, or sometimes they can also be generalized. And in this case, the material that is being excluded from the body includes the necrotic material, collagen, and sometimes can also be elastic tissue. It is associated with diabetes, chronic kidney disease, and rarely you can also see it in patients having liver conditions. Then we have also the perforating calcific elastosis. This is very, very rare, more common in the black women, and ounce is rare in adulthood, commonly located in the abdomen and the periumbilical area. And in this case, you are eliminating the calcified elastic tissues. So someone will have either malparity, like they have very many pregnancies, then they have maybe weight gain, obesity, hypertension, as the other comorbidities that can give you a risk of getting this particular perforating disorder. So we can also have other secondary perforating diseases that can actually give you this similar picture. So these things can either be grouped into endogenous substances, so that can include things like hematomas, then perforating pseudoxanthoma elasticum, then you can get perforating calcinosis, gout, you can where you have now uric crystals being eliminated from the skin. Then you can have another group as granulomas, where you have perforating granuloma annuli. We can also have necrobiosis lipodicus, common in diabetic patients. We can have sarcoidosis, also causing perforation, as well as rheumatoid and nodule. Then you can also have exogenous foreign material that can also either cause perforation. These things like wood splinters, the silica, all this can come from outside and then give you a perforation through the skin. So as I told you earlier, so sometimes the perforation is from up going downwards or from down going up. So, like for example, in a wood splinter, the perforation, the wood splinter is coming from outside the body, going through the skin. So it's also becomes a perforating dermatosis. Then infectious conditions like chromoblastomycosis can also have a perforating aspect, leprosy, and then also schistosomiasis. Then also we can have as tumor cells like melanoma, Paget's disease, even MF, mycosis fungoides can also give you perforating picture. So as you can see here, this is an example of an acquired perforating dermatosis, where someone having it following a line, what we call cobnalization. And in this case, you can also see it in acquired perforating dermatosis. As you can see down as well, we have all these keratotic papules with a central core, and that is usually characteristic of this perforating dermatosis. So when you continue downwards, we see that acquired perforating dermatosis, these are usually involve a transepidermal elimination of substances, usually degenerated collagen or elastic fibers, and this has been associated with diabetes and then also chronic disease. In some literature, you find it being called acquired reactive perforating dermatosis, or sometimes you find it just being called acquired perforating collagenosis, but this actually mean the same thing. That's the confusion I was saying you about. And the arrangement, you see these keratotic papules with a central core or plug that has keratotic material. So when you remove this, you see that there is that hole or that punctum at the center of these keratotic papules. So continuing further, the clinical picture, in this case, you'll have it being prevalent in about 4 to 11% of the hemodialysis patients, primarily occurring in about 50 to 60 years, and more common in females compared to males with a ratio of 3 to 1, and it can affect all races without any predilection. And then the presentation, someone will have these very itchy keratotic papules or nodules, typically on the trunk and limbs, and the pruritus can be very, very severe in these cases. So when you take off a biopsy, you will find that you have transepidermal elimination, which will occur due to so in pathophysiology, you find that they have transepidermal elimination, which occurs due to the degradation of collagen and elastic fibers by enzymes on the leukocytes. So because of this damaged collagen and elastic tissues that are being broken down, the body needs to get rid of these things. So that's why they end up going through the epidermis to go to outside. Then it is observed in patients with diabetes or CKD. So in the histology, we see these typical cup-shaped epidermal invaginations with necrotic debris, and then also with vertical collagen bundles. So this is the arrangement that we are talking about. So because you are having material being excluded or eliminated from the lower layers of the skin, that is like maybe the dermis or subcutis, through the epidermis to the surrounding, to the outwards. So you'll find that you'll have this cup-shaped, you see like this arrangement here. If I do like this, so that's like a cup, another cup is there. And then you have this vertical arranged collagen, which is which opposes the usual arrangement. You see now this is vertical arranged collagen, even the same arrangement here. But you know that our collagen is usually horizontally aligned when you look at the dermis. So you'll have this plus a little bit of inflammatory cells that are maybe infiltrating these particular areas. But then these are usually intercepted by normal areas like here. So they are only occurring at a particular section. So that's how histology will give you, or that's how it will look like on histology. Then it can also have the familial type of reactive perforating collagenosis, which usually starts in the childhood, triggered by trauma, but it can resolve within weeks. And someone will have papules and on hands and elbows and the knees, and may also show some form of communalization. You can also have it being verrucous, the verrucous perforating collagenoma. In this case, it is also triggered by trauma with foreign material, especially if someone is working in those industries with fiberglass or even calcium chloride, they can present with this type of acquired perforating collagenoma. So in this case, the body is trying to eliminate the fiberglass, those tiny particles. You know, fiberglass is used as an insulator. So people who work in fiberglass, because it's an inert substance, they can end up with fiberglass dermatitis, which can now give you the verrucous perforating collagenoma later on in the process. So we see that in this case, it will present as verrucous papules, and you have to make sure that you're not making a diagnosis of warts when you see that picture. So this is how it will this will look like. So this is also another picture to show you how the perforating acquired reactive perforating dermatoses will look like. You see these papules and plaques that have this central core that is whitish, showing you this elimination of this abnormal material through the skin. So when you look at this, the differential diagnosis will be a little bit many. You can think maybe it may look like molluscum contagiosum, because in molluscum it gives an umbilicated papule which has a whitish punctum at the center. So it can also look like papular urticaria. It can look like other perforating disorders. But remember, it can also look like the prurigo nodularis, the one we commonly see in patients living with HIV. The management option, some cases can resolve spontaneously, but at times you may end up needing to give other things like allopurinol, retinoids, isotretinoin, methotrexate, or even emollients and topical steroids to try and calm down this extensive pruritus and this elimination. Then in case the things fail, you can also opt for light therapy, where you can do narrowband UVB or even PUVA, or sometimes if you are in a better setting, you can also do photodynamic therapy, which can also give us relief, especially with the pruritus that comes along with this dermatosis. Then we can also get the perforating diseases due to exogenous agents. So in this case, something comes from outside, maybe it's a chemical, it's a foreign agent, then or something injected into the skin, people who do tattoos, people who do piercing, ear piercings and the rest. So the body can try to eliminate those foreign materials that you have introduced in the skin. So they can be chemicals or foreign agents. So examples in this type, we can include occupational exposure. In this case, someone gets a reaction, usually, and it's reported after contact to either caustic grills, fluids, or even petrochemical industry, to the oils and those other materials in those industries. So someone gets exposed, and then those materials, like even fiberglasses, can also be occupational. Then the body tries to eliminate them. So other things like calcium-containing products have also been reported to cause similar manifestations, especially the calcium-based EEG paste and exposure to calcium carbonate in drilling mud. So these people dealing in oil industry and construction industry, they can present with this type of perforating dermatosis. Then other things like intradermal injection, where you have now things like following steroid injection, or even following this other normal injection like benzazine penicillin injection. Someone can end up getting a perforating disorder when the body tries to eliminate those foreign things that you have included. Include things like tattoos. In a clinical presentation, someone will have something like a tender papule with a central amplification and an ulcer shortly after they have been exposed, and then you have to stop those particular agents. So this picture tries to actually show you how they can look like in different patients. For example, here, so that someone who's had a perforating papule there, amplificated papule with a whitish center, and this is how histology will look like. All the time you see that the body is trying to eliminate something there. Even here, the body is trying to eliminate something there. Those cup-shaped picture, the same thing here. The body is trying to eliminate either collagen, elastin that is abnormal, the same thing here, and then the same thing there. Okay, so when you go to the elastosis, perforans, Pathogenesis or EPS, so this is also a rare perforating dermatosis characterized by extrusion of elastic fiber through the epidermis, and in this case, it can also be called the perforating elastoma. As we've seen, the names have been changing over time, or some people call it elastoma intra papillary perforans. The first guy that described its story, that's the name he gave it, and now you will see that it's a little bit rare, but typically it occurs between the ages of 5 and 20 years, predominantly affecting males, and it can occur in all races. So 40% of patients with this condition have been associated to have other connective tissue disorders, ranging from Ehlers-Danlos syndrome, the Marfan syndrome, Down syndrome, and it can also be induced when people are started on penicillamine as a medication. So this is one of the conditions that can be triggered by penicillamine. So when you continue, so in its pathophysiology and pathology, so usually the predisposing factors, someone will have a primary defect in the dermoelastin, causing triggering or offsetting the extrusion, and then common in areas of trauma as well as those areas that have friction. In the histology, someone will have elastic tissues in the dermis with epidermal hyperplasia, and oftentimes they give a reaction that looks like a foreign body giant cell reaction. And if it is penicillamine is the cause, usually it has a unique picture where it gives you a lumpy, bumpy, elastin morphology. So that is for the pathologist, but for you to remember that if it is penicillamine and then you're suspecting a perforating elastic disorder, so you'll find that when you take off a sample, the pathologist will give you that comment that I've seen maybe a lumpy, bumpy elastin morphology. So in the clinical picture, still someone will have these small asymptomatic papules, usually arranged in a serpiginosa or wavy pattern, and papules usually develop into rings about 10 to 20 centimeters in diameter with a central plug. So commonly seen on the neck and the cheeks, but also on the arms, thighs. Sometimes it can also be bilateral. So this is how the papules will look like. So they have this wavy pattern and giving you that that's why they are called spinosa. You see this polycyclic pattern. So they keep moving, and then that's how they look like. So the same thing here, and then you can see here at the center, you have these things being extruded from or eliminated from the skin. So that's how it will look like. So in this case, someone had papules also on the neck at the back there with annular configuration, and then here that is the spinosa configuration or serpentine arrangement. Then this one was occurring in a patient who already had Marfan syndrome. So that's the picture. So still when you see here in this histology, we are seeing all this arrangement trying actually to break through here so that this component can be eliminated. Then you see these other ones that are going through the epidermis so that they also get what? Eliminated. So when you look at the diagnosis, usually when you do a skin biopsy and you do histology, it will be a little bit characteristic to show that something is getting eliminated. And these lesions can mimic other dermatoses like the folliculitis. But you know, in folliculitis, we usually get the lamella arrangement within the epidermis. So it has to be also a little bit different, and it will be a little bit easier for you to tell are different. But it can also look like the granuloma annuli on histology, and you have to be very keen to make sure that you don't misdiagnose it. Then Severity, usually it is not prognostically significant, may indicate an underlying connective tissue disorder. So when you see it, you can start to screen out for other things like the Ehlers-Danlos syndrome, the Marfan, the Downs, to make sure that child has no other coexisting connective tissue disorder. So in terms of treatment, the first line usually we call it benign neglect, or just observe the patient and see most of the times EPS resolve spontaneously, but in case you need treatment, you can do things like curettage, cryotherapy, or even topical retinoids, which have a comedogenic effect. And in this case, we're just only doing cosmetic improvement, nothing more. And then you have to avoid excision or even ablation, which is the risk of scarring that can come with those other procedures. But in other advanced therapies like the pulse dye laser, the CO2, Eddy and Young laser can also be tried depending on the outcome. But in this case, if you're doing laser therapy, you may need to first give a shot at maybe 1 or 2 lesions. Then after that, you observe how they respond. If the response is desired, then you can go ahead and do the rest. So, and then you do the rest of the lesions. So in this summary, this table now tries to show you the different or the majority or the major perforating diseases and how they look clinically, histopathologically, and then the common association. So if you are to start with the familial reactive perforating collagenosis, also just called reactive perforating collagenosis, we've seen that it is a little bit rare, commonly in children, and having equal distribution between males and females, commonly seen on upper extremities with keratotic papules that develop even on site of trauma. We say that that is called cognalization, and most of the times they can resolve spontaneously in about 6 to 10 weeks. So still in the histology, we see that collagen is the major fiber that is being eliminated, and you'll find that sites of minor trauma are affected, and then also collagen perforates, and then what you have to understand, it is on the upper extremities commonly. So when you go to the acquired perforating dermatoses, remember I told you that the acquired one, now they are grouped together. So it has a cocktail because there's a thinking that at first they just used to call it acquired perforating collagenosis, but now they discovered that even elastin fibers is part of the cocktail that is being eliminated. So it's just now classified together as acquired perforating dermatosis. So it includes the acquired RPC and then also the Child disease. So a little bit more common onset is usually in the adulthood, and you find that it also has an equal distribution in male and females. Then the diabetics and renal patients are commonly affected with intense pruritus, and oftentimes it loves the legs, or it can be generalized, and it can also have cognalization, and still you'll have the central keratotic plaques. So it can also resemble the RPC commonly. So you find that you cannot clinically distinguish it from RPC, and always you find it associated with diabetes or even renal failure patients, and it loves more mainly the lower limbs. So you'll find that in this case, the first one, the familial type, common in the upper extremities, but the acquired type loves the lower extremities. Then the next one is the elastosis, perforans spinosa. So in this case, it's a little bit still rare, but it can occur either in childhood or early adulthood, and you find that for it is more common in males 4 times compared to females. And you will see this annular or even serpiginosa plaques with keratotic plaques along the rim, and then you find that most commonly it can have the lateral neck, or it can also be on the face, the arms, and then the facial areas. So you'll find that when you do histopathology, you see keratotic crusted plaques surrounding epithelial hyperplasia, which you call a crab claw sign. And because of this, you will be able to actually make a diagnosis and distinguish it from other lesions that can also give you such maybe an annular pattern like granuloma annulare, where clinically on the skin. Then you find it being associated with other syndromes like I remember this, I usually love it. It's called MAD powers, where MAD stands for Marfan syndrome, then acrogeria, Down syndrome for D, then other things like penicillamine, this is the drug that has been associated, then osteogenesis imperfecta, it's also associated with elastosis, perforans, spaginosa, and also Rothman-Thompson syndrome and eladandros as well as scleroderma have all been associated with this elastosis, perforans, spaginosa. Then it can also occur in Wilson's disease or even cystinuria, where you have patients being started on the D penicillamine. So because of this drug, at least remember that it is one of the drugs that has been linked to a perforating disorder, penicillamine. Then the last one is what we call the perforating calcific elastosis. This is a little bit very, very rare, commonly seen in the black women. And in this case, they usually have plaques on the abdomen or the periumbilical area, as I mentioned earlier, with their peripheral keratotic plaques. And in this case, you have transdermal elimination of calcified elastic fibers. And in this case, commonly you have the association is with obese or hypertensive women who have had multiple children, multipalous women who are even black. So commonly the lesions are the umbilicus or even the periumbilical area. So in summary, if you're looking at these perforating disorders, so these perforating disorders, you can choose to understand them in this way. The first understanding can be either are they acquired or are they familial or inherited. So when you look at the ones that are inherited, usually we just have one, the familial reactive perforating collagenosis. And remember, in this case, the onset is a little bit early in childhood, and it will be common on the upper extremities. Then you can also look at them if they're acquired. So if they're acquired, then we have majorly two. They acquired reactive perforating, now called dermatosis, because it includes both collagen and elastin. Is that okay? So then, in that case, it comes in a little bit late, adult onset, and the features will be similar, but in this case, they'll be commonly seen on the lower extremities and commonly in patients with either diabetes or the disease. Then when you go to the next one, then the elastosis perforans vaginosa, you've seen this having either an onset in childhood or even adulthood, more common in males than females, and it's the one that is associated with a lot of conditions that include the Marfan syndrome, Downey syndrome, scleroderma, Ehlers-Danlos syndrome, the Rothman-Thompson syndrome, the osteogenesis imperfecta, the use of penicillamine as a drug. Let's say that you have that picture. Then remember, we also talked about the perforating dermatoses that can be secondary to other skin conditions. Either you have a tumor that is being eliminated, things like melanoma, they can give you a perforating dermatosis. Then other things, they can be endocrinological, other things can be infections, then other things can also be other materials like foreign materials like occupational dermatoses that can end up giving you perforating disorders. So I hope this video is helpful for you to understand these conditions. See you in the next video. God bless you. And remember to share with your colleagues. Thank you very much. Have a good one.